Now, here's another question. Is there actually a serum estradiol level at which we know we're going to have cardio protection? And the data for this is even more sketch than the bone.
Any woman who is following any creator in the menopause space is immediately going to think gynecologist, medical doctor, qualified, because that's what we've been taught to believe. Hey, I'm Holly Warner. Welcome to the Patient Pod and Fix What They Missed. So let's fix what she missed.
Now, a lot of what we extrapolate as far as cardiovascular risk reduction and estradiol levels is actually from this MESA study, but it's looking at endogenous estrogen levels. That's estrogen levels that are coming from our body, not what we're taking from hormone therapy. Now, what this study shows was that the higher the estradiol levels, the lower the risk of cardiovascular disease among postmenopausal women. But at no point is there an inflection at the 100 picograms per milliliter level.
So apparently we don't have any numbers anywhere in the literature that show where you need to be for cardiovascular protection. And this video had somebody comment about a colleague of mine, Dr. Amy. She's awesome. She has been in this space for a couple of years now, but she digs deep into the literature. The video says that we don't know serum numbers and that there are some loosely quoted numbers being thrown around. She goes on to mention a study that was done on endogenous hormones. And when we use the term endogenous, what it means is what our body is producing. So these hormones that our body naturally produced did show what level our circulating estradiol was at, where it gave us the most protection. And when that level dropped, the protection went with it. But for some reason in her video, she's making it sound like this study doesn't matter because it was done on the hormones that we naturally produce, not on hormones that were given, not on hormones that were prescribed. And I'll never understand that logic. There was a specific number that was mentioned, and I'll put it up in the post here. It was 100 on the lab level, so 100 pg per ml, which is picograms per milliliter, which is the level that was referenced in the comment. We really need to stop telling women that studies are irrelevant. Data is data, and we have lots of data. We have data dating back to, like in 1991, we had studies. That's data. If a study is small or if a study is done on women on hormone therapy or not on hormone therapy, it's all data and it's all relevant to the menopause discussion. This clearly showed that when women lose estradiol, their cardiovascular disease protection goes down with it.
Now, when you look at studies like the ELITE trial, what you see is that giving estrogen to women that are within a 6-year window of menopause has a beneficial effect on plaque progression, versus when you give it to women greater than 10 years out of menopause, it has the opposite effect.
Then she mentions the ELITE trial, which is awesome, and it gets referenced quite a bit, not just the WHI, which showed that giving oral estradiol specifically, which I love because it's not the conjugated equine estrogens, it's not giving what we call a synthetic estrogen, for lack of a better term. This gave women 1 milligram of an oral estradiol, and in a 6-year window post-menopause, it was beneficial. It had a beneficial effect on plaque progression, versus women that were given the same dose, 1 milligram oral estradiol, and they were past the 10 years plus that window of menopause. So the day that you get your last period is, ta-da, menopause. 10 years past that, sorry, no more benefit, no good, you don't count, you've lost out, which is bullshit, because that's not what the literature says. Does the benefit become less in many of the categories? Yes. Do we lose some of the benefit? Absolutely we do. But do we lose all of the benefit? Is there no point, no benefit at all? That's not true. We need to stop telling women that this is the case, because it's not. We saw that she says it had the opposite effect. It did not have the opposite effect. It had a pretty similar effect to a placebo, in which for what they were studying, there was no benefit found. You need to review the compound used. We know that it was oral estradiol. That's the root, that's the compound. And then you need to look at the effects reference, right? Where does this 100 picogram per milliliter come from? We've got the EPAT We've got the elite. We've got a number of different studies that did sort of talk about the levels where we saw benefit versus the levels where we didn't see benefit. She's saying it's extrapolation and not evidence, but if we say that we're trying to achieve the early follicular levels as a goal, that's going to be anywhere between 30 and 100. Well, there's some numbers for you. Why are we not counting those numbers? So yes, we used an exogenous estradiol. Why are we discounting the endogenous? We're talking about this endogenous study where our body is producing it, and then she's discounting it because that's what your body naturally made. It was one piece of a larger picture that actually includes many RCTs. If you take the literature and you look at one study, you look at another study, and you put it all together, you get a pretty big picture of what's going on. It all collaborates one mechanism, and it's not meant to be a whole argument. It's meant to be part of the argument. The mechanism itself, though, it doesn't change. It doesn't care where that estradiol came from. You're still going to get that same benefit, whether it's exogenous or endogenous, whether you've taken it or your body has produced it. We know that the estrogen receptor alpha mediated effects on the endothelial function and lipid metabolism, for example, respond to circulating estradiol, regardless of if it is circulating because you took a little pill or it's circulating because your ovaries spit it out. So my question becomes, why are we ignoring shared receptor biology? The elite trial used 1 milligram oral estradiol. It didn't use estrogens. We know that in other studies, a more appropriate dose, a better response in some cases was 2 milligrams, but not every woman can tolerate 2 milligrams. So 1 milligram is good. For some, 1.5 might be better. For others, it's 2. For me, it's 2 milligrams to get me to the threshold that I want to be at based off of the literature to give me the most protection that I can get, to put me ahead of the game. If something's going to happen, it's going to happen, but I'm going to do my best to prevent it, which means lifestyle factors, hormone interventions, all of that. So for me, my dose is 2 milligrams every single day, and that gets me to exactly where I need to be. 1 milligram, 6 years post-menopause was good, but 10 years out, she said it caused harm. That's an overstatement. Early post-meno, under 6 years, CIMT was reduced by 0.0078 millimeters per year in the placebo versus 0.0044 millimeters per year with the estradiol 1 milligram group. That's a statistically significant benefit. The late group, which is the 10 years out and beyond, the CIMT and placebo plus the estradiol groups were pretty similar. So no harm, just about the same. So if there's harm, the harm came naturally, not because we gave it after the 10-year window, but because it just didn't have the same benefit. Because again, the timing hypothesis comes into play. Early intervention is best. Her claim isn't supported by the numbers. But then you look at the EPAT, which was estrogen in the prevention of atherosclerosis trial. 222 healthy postmenopausal, aged 46 and beyond, no cardiovascular history, randomized, unopposed, oral estradiol, they used estrace, 1 milligram per day versus placebo, followed for 2 years.
The American Heart Association identifies estradiol as being cardioprotective, but no threshold has been established. ACOG and the United States Preventative Task Services again recommend against estradiol being used as primary prevention for heart disease. And I think given all the studies, it just has to be, again, an individualized decision, understanding that starting younger helps, starting older may not, and there's no established threshold for estradiol level.
So we've got a study, 222 healthy postmenopausal women. We see what the placebo groups had, and then we also see what the non-placebo groups had. So there's some numbers that are pretty awesome up there. The estradiol specifically group didn't just slow down, it actually reversed, with CIMT regressing at 0.0017 millimeters per year. That's regression. It means it goes away. That's benefit. It's real plaque regression, not just stabilization, and it's statistically significant. So why are we forgetting about that? Why are we not talking about that? There's also another really important nuance that I think needs to be mentioned here, is that the benefit was concentrated in women, not on statins, not on lipid-lowering therapies. Women already on statins did not show additional benefit, which is an interesting nuance because we do see in a lot of the trials that are out there that as a secondary intervention, meaning a woman has already had a cardiovascular episode, we see benefit from statins. But for primary disease prevention, we don't. We don't see that same result. So if you've never had a heart attack, you've never had a cardiovascular episode, obviously there's caveats to that. Why are we putting you on a statin instead of oral estradiol? So when I see a clinician out there who's saying that it's extrapolation, it's not evidence, to me that's ignorant. Haven't women suffered enough? Why are we still fighting amongst ourselves? Listen, some of these people out there haven't been in this space for more than 3, 4, 5 years. This space became popular and everybody wants to be a part of the conversation, but you can't be a part of the conversation if you're not up to date on the literature. If you're not looking at all of the studies that are out there globally and looking at that data, then you're behind the marks. Because we don't have as many studies or as large studies as we'd like to have when it comes to women's health, we have to do the best that we can. And saying no to something that has a little bit of evidence based off of I want more evidence is doing a disservice to women. American Heart Association, the AHA, identifies estradiol as being cardioprotective, but no threshold has been established. We all know the guidelines are at least 10 years behind the mark. Doesn't mean that the data doesn't exist. It means that they err on the side of caution, if you will. You know what I recommend? I recommend that they fuck right the fuck off. Do you know why? Because what they are saying isn't supported by the literature. Go by the literature. And you know what the literature says that's really cool? Now I'm going to give American stats because most of the people that are watching tend to be out of the United States. But we can take this for Europe. We can take this for Canada. We can, it's sort of the same across the board. So 1 in 8 women will develop breast cancer. This is what scares us about hormone therapy. Even hormone therapy has been shown and has always been shown not to cause breast cancer. We still have a fear based off of a poor interpretation of the data in a study. It was interpreted incorrectly. It's not what the study said. It's not what the data said. They did not say that these hormones caused cancer. In fact, we saw on the estrogen alone arm that it actually decreased. 1 in 8 women will develop breast cancer. Okay, fine, but what about all of the other things that are a risk factor and are very serious if we don't have estradiol? So if you're going to avoid estrogen therapy based on a fear of being part of that 1 in 8, what about the whole 1 in 4 will develop dementia? That's not a life that I want. What about 1 in 3 over the age of 40 will develop mental health issues? What about 1 in 3 women will develop cardiovascular disease? And that just so happens to be the #1 killer of us ladies. How about 1 in 2 women will have an osteoporotic fracture? That means you and I are watching together this video. One of us is going to have an osteoporotic fracture most likely because it's 1 in 2. And it's not going to be me because my bones are protected. I know what my bone density looks like. I'm 48 years old. I take 2 milligrams of oral estradiol. My levels are 256 pmol per liter on a Canadian lab panel. Actually, it's not. They went up. It's 264. So I got all the protection that I need. I feel great. Yes, my symptoms are managed, but also I know that I have protection based off the literature. So that 1 in 2 isn't going to be me. And I want to quote Dr. Noor. She's awesome. She made a statement where she said, we need to stop letting providers, doctors, NPs, PAs, whoever's doing the prescribing, whoever your provider is, we need to stop letting these providers who are not up to date with what the most current data says. They're still quoting data from back in the early 2000s. We need to stop letting them rule our lives. We need to stop letting them dictate hormone therapy. Women, we are more than our breasts. We are an entire body with multiple systems. So if my risk is 1 in 8 for breast cancer, but it's 1 in 4 for dementia, I don't want to end up with a brain that's mush. I don't want to end up with cardiovascular disease. I'm going to do everything I can to prevent that with hormone therapy. And guess what? You're still getting protection against breast cancer with hormone therapy. That includes progesterone, which is apoptotic to breast cancer. That includes estradiol, where even if you were to develop breast cancer, your outcome is better having been on estradiol to start with. This video is here to correct the misinformation because that's what I do, and it's what I've been doing for over 2 decades. I started advocating for women in the early 2000s when I saw that the study got it wrong. I opened my first clinic for hormone therapy specifically in 2014. I started my own training back in 2010. I waited 4 years before opening my first clinic, brick and mortar, for hormone therapy for women. It is now 2026, and I am still deep in the literature every single day, including Sunday over my morning coffee.